Okay, so for this audio lecture, we're going to be focusing on allergies. We'll also be looking at all the hypersensitivities, just so you have an overview of that. But again, we're going to be focusing primarily on allergies, as that was what the class voted for one of their final topics for this semester. So any of your immunology textbooks are going to have a kind of classic figure that gives you an overview of the 4 types of hypersensitivities. So type 1, 2, 3, and 4. Type 1, 2, and 3, those are characterized by the immune mediator being antibodies. You can see that there's different types of antibodies that are going to mediate this, that's going to initiate the response, the hypersensitivity, the over response to small amounts of allergen, of target for the immune system. Type 4 response, this is known as a delayed type. Usually this is seen days after exposure, where type 1, 2, and 3 are usually seen shortly after exposure. Also with type 4, this is characterized by not antibodies, but T cells. So T cells become activated and respond to the target, to the allergen. So again, we're going to be focusing primarily on type 1, which is the allergy response. So for allergy response, it's the IgEs that are the antibodies that's responsible for that. What happens is that they're going to bind to basophils. And so when they bind to the basophils and their allergen, that actually causes the basophil to degranulate. You might remember that basophils have histamine in them. Similar mast cells also contain histamine, so we can also see mast cells involved in this response. When we get the histamine release, that causes vasodilation and constriction, so it changes your blood pressure and such. And then it acts as a chemotaxis, so that it calls in additional immune cells to the location. So if we're looking at a type 1 response, many of us, especially right now in the spring, are very familiar with allergies. So this can range anything from, having something like hay fever, pollen allergies, to food allergies, to having hives, eczema, asthma. So these responses are all considered a type 1 response. And again, that's because they're characterized by having IgGs to these allergens. So we'll talk about how you can test for allergies, but this is where, when they're doing the test, they're looking for degranulation of basophils, and the way you can see this is by hives. Okay, is one of the classic ways. But the things like runny noses and all the other symptoms that you would have with an allergy are also part of that, and that's because of that histamine release and also different cytokines. And again, we'll talk more about that. Keep in mind that for allergic reactions, they can be more severe. So we can have something where we have anaphylaxis. So this is where the swelling becomes so severe that people have issues moving air through the airway. And we could also have drops in blood pressure and such because of the changes to the vascular system. Now, looking just briefly at the other types of hypersensitivity, type 2, this is where we're going to have IgGs or IgMs involved. And so they're going to end up binding to surface antigens. So this is where a chemical like penicillin can be bound to the surface of the target cell. And antibodies recognize that. And so they what we have is these Fc receptors end up binding it, and they become activated. And again, the antibody that's usually involved in that is IgGs or IgMs, and then they can cause activation. And then for type 3, this is where immune complexes form. So you can see how these antibodies are binding to the antigen, and they actually kind of clump together, or you get this agglutination reaction. And this can cause activation of the complement. And so we get activation of complement, and neutrophils come into the area and respond. And so some of what we classify as autoimmune disorders like rheumatoid arthritis, lupus, these are actually caused by a type 3 response. And then with type 4, as I mentioned, this is where we get T cells activating. And so the T cells are going to recognize their antigen, they become activated in producing cytokines that can cause either direct damage or indirect damage. So we can see this with like contact dermatitis. In some cases, diabetes, type 1 diabetes is sometimes classified as a type 4 response for that. So again, you should have an understanding of all 4 of these different types. So you could match them with their immune mediator or their description. You should, have an example of each one. And again, we'll talk a little bit more. You'll have an opportunity during class to ask any questions about that. But again, for the rest of this lecture, we're going to focus on type 1 responses, where again, those are going to be allergic responses. So there's a number of things that we can have allergic reactions to. So they can range from pollen, so environmental exposures. We could also have hypersensitivities to different drugs. Again, those classically are not type 1 responses. Those could be type 2 responses and even type 4 responses. We can also have food allergies. And so we'll talk a little bit about food allergies, but also, and keep in mind, we'll talk a little bit about the hygiene hypothesis and how that can affect how we're becoming a society with more allergies. And some of that, the hygiene hypothesis is that there's shifts in our microbes that are present, and that causes us to respond to things that we didn't previously respond to in prior generations. Also, different insect products we can have hypersensitivities to. So things like different venoms, dust mites, people can have allergic reactions to that. There's other allergens like amyl dander that fall into the category of allergies. So the general mechanism of a type 1 response, again, these are classically a more immediate response. So within minutes of being exposed to the allergen, you're going to start to see the symptoms. So again, think about you're going out for a nice walk, and within a couple minutes of being outside and walking around, you start getting a runny nose, your eyes are itching, you're getting that post-nasal drip, sore throat now, congestion and such. And we'll talk about how you treat for allergic reactions. And one of those strategies would be to take an antihistamine to block the release of the histamine, to block the effects of the histamine. So again, what we're seeing here is that we have our immune cell. It's got the B cell has their antibodies on its surface. It's going to undergo isotype switching or class switching. So keep in mind that that constant segment is going to change. So it's epsilon. So that's how we're going to get this B cell, so that it is producing IgGs. Okay, so IgGs on its surface, it's going to secrete those. And again, these IgGs are the ones that tend to lead to a type 1 response. And so the antigen binding sites are going to recognize some kind of allergen, right? And an allergen is foreign, so this is a good response, right? We're responding to something that's not our own. The problem is we're being exposed to it in our environment, in our diet, in our lifestyle in some ways. And so we'd prefer not to have this response, but again, it's meant to be protective so that the pollen doesn't, injure us or damage us. It's foreign, right? So these B cells were never selected against, because again, you wouldn't express these pollen proteins, the proteins that are in the pollen. So what happens is the constant region is able to bind to the Fc receptor on the mast cell. So here we have a mast cell. This also could be a basophil. So keep that in mind too. And so they have these receptors, which are called Fc receptors on their surface. And we'll talk a little bit about those in just a moment. But these Fc receptors have a binding site for the constant region of IgEs. And so you can see how we have our complex forming here. So now when we come exposed to the allergen, because we've walked in that beautiful meadow with all the flowers around it, the allergen is able to bind to that antigen binding site on our mast cell. This signals, because of cell signaling events, this signals for the mast cell to degranulate. So it's going to release the histamine, heparin, proteases, all these different chemicals. And again, the one we tend to focus on is histamine. And these chemicals have effect on a number of different target cells. So there are a number of different target cells that have receptors that are able to sense histamine. So there's 4 different receptors for histamine. So H1, H2, H3, H4. And some of these are found throughout your body. So your smooth muscle cells, your small blood vessels, your mucosal glands, right, that are going to produce mucus, your blood platelets, your nerve endings, including nerve endings that are in your central nervous system, also in your peripheral nervous system. And so that becomes important when we talk about drug treatment. So just keep that in your back of your mind about the central nervous system. They have receptors, and also xenophils also are going to have receptors. And so all of these different cells become targets, and that's where we start to see the different effects that we present, the different symptoms of an allergy. And there's, you know, different things in play, and as far as how much of the allergen is present, how many times you've been exposed to it, your just underlying immune system, some genetics factors that put you at risk. Okay, so just looking at that FC receptor, you can see how it is going to have transmembrane domains to it, and then it also has the ITAM domains that allow for cell signaling, right? So ITAM, we've seen that in other receptors, and ITAM allows for cell signaling events. So FC receptors come in different forms. So we can have a high affinity FC receptor or a low affinity FC receptor. And so they are able to bind to those IgGs. And again, they then take that information. So IgG binds the allergen, that signals to the FC receptor, which then signals to the ITAM to then activate cell signaling events like such. So here we can see how we have activation of MAP kinase, PKC, NF kappa B, and those are going to cause different events as far as production of cytokines, degranulation, being present. Okay, you'll notice that CCAM is here, and again, that becomes important because some of the drugs that are used to treat mast cell degranulation are targeting CCAM, because CCAM is important for the degranulation events. So again, keep that in the back of your mind when we talk about treatments later on. So again, the basic overview of what's happening in a type 1 response when we have mast cell activation, or again, you can think of these as basophils, you're going to have your, resting basophil, mast cell, basophil. You're going to end up having these IgGs that are going to bind to its surface, and then the antigen binds, and that's going to cause signaling of degranulation, activation of the mast cell. So again, first what's going to happen is it's going to release those granules and all the content in there. And then we're also going to get cytokines, chemokines, growth factors, all these different mediators being produced. And again, those are going to have effect on those different cell types. Some of these are going to be short-term effects, and other ones can be more longer-term effects. So short-term effects, again, you're going to see things like mucus production. You're going to see things like being the itchy eyes, itchy skin, but then we can also have more long-term effects where we can have inflammation occurring, and that inflammation can cause activation of additional immune cells, and can have other symptoms such as like joint pain and such, and can cause damage of tissues if there's long-term inflammation. So this looks like just some of the different mediators, and you guys know me, I don't expect you to memorize every single one, but you should definitely have an understanding of the ones we're talking about, and how they're playing a role. And I think for most students, it's kind of interesting to think about, like, well, I've had an allergic reaction, like what's going on in me. So what are the different, if we got on our magic school bus, what are the different chemicals that we would see being involved? Again, histamine is one that has been largely looked at, both for mechanism, but also for treatment. And so again, we're going to see that it's going to cause an increase in vascular permeability. We get smooth muscle contraction. So again, you think about if you took anatomy and physiology and you learned about the different types of muscles and smooth muscles and where those are all located, you can start to understand some of those symptoms that you're feeling. In rodents, it's been shown that serotonin has a similar effect of histamine, though that role has not been shown in humans as of to date of our textbook here. There are chemotactic factors that are produced so that you draw in eosinophils and also neutrophils. So again, you are recruiting in additional immune cells. And so this is where, when we get inflammation, we have these immune cells present to add to the inflammation. So think about unit 2 with innate immunity, and when we talk about inflammation. We also have these proteases that are going to be produced. So the proteases are going to be important because they're going to be able to protease, cleave proteins. And so this leads to mucosal secretions. It allows for more permeability of the blood vessels, because what's going to happen is the basement membrane of these epithelial layers is going to be kind of broken up by these proteases. So it makes it so that there's it's more permeable for moving material across, because we want to be able to get cells out to that area and such. And sometimes what we can see in the gut happening is what's called leaky gut syndrome. We also have other factors like platelet activating factors, prostaglandins, bradykinins, and these are all help with permeability factors. And then we also have cytokines. And again, cytokines are going to help to recruit in additional cells and help. And again, idea is you're trying to clear the allergen out to get rid of it. But again, the runny nose and all those other side effects are, part of the downfall of that. When we look at an allergic reaction, we can break it into 2 responses. So we have an early response that happens, and then a late response that's going to happen. So you can see on the left side, we have our early response, what we've talked about as far as our mast cell becoming activated and degranulating, releasing different factors like histamine, prostaglandins. This is going to cause changes to cells like the blood vessels, to mucosal glands, so we get mucosal secretion. We're also going to have cytokines that are being produced, so we recruit in inflammatory cells. As this response progresses into late, what actually ends up happening is that we start to see damage being done to that tissue. This is looking at asthma. So this is looking at like a bronchial passage. And so again, you can see the normal structure of the bronchial passage. In early response, a nice even layer of our basement membrane. But as the tissue is being damaged, as we get that increased permeability, as we start to break down the basement membrane, it actually starts to thicken. We also get the loss of our cells that are going to be really important for oxygen exchange. And so we get an influx of eosinophils in the area. Again, all of those are trying to fight that allergen, clear out that allergen. But what happens is we're actually ending up damaging this tissue. And that's where someone with severe asthma is going to have problems with gas exchange in their airways, in their lungs. And then we can have, left untreated, we can have scar tissue building up and such with chronic asthma. So we want to keep in mind with type 1 responses, again, they can range anything from just localized reaction, where we might get something like hay fever, atopic dermatitis, to something that's more severe, life-threatening, where we have anaphylactics or severe asthma occurring. So they really do run a range of different responses. And again, what characterizes them is not necessarily their symptoms, but the fact that they're initiated by the IgGs activating mast cells and basophils. Okay. So as far as how do the different symptoms arise, it really depends upon how the allergens enter in your body. This becomes important later on when we talk about treatment. So depending upon how the allergen's entering, whether it's you're breathing it in, whether it's being injected, or whether you're taking this in orally, this can change the symptoms that are presented by this type of reaction. Also, the amount of the allergen present changes the clinical symptoms. Also, if you've had prior allergen exposure and how long that has been. And there's also genetic factors that also play a role. So we know that there are certain genes that put you at risk of developing allergies and such. Now, one of the things that they do see clinically is what's known as atopic or allergic march. So where your allergy can change over time. And so the allergies you have, if you have an allergy as a child, you might kind of grow out of it. You might develop new allergies or different allergies. And so here they're talking about how you might have something like an atopic dermatitis as a young child, but then that might actually develop into asthma or food allergies later on in life. So looking a little bit more at food allergies, you can see how we can have different disorders that we characterize, that clinically they're characterized by. So we can get these, again, these are going to be IgA mediated. We can have ones that are acute, so again, kind of short-term responses, or we can have ones that end up recruiting in additional immune cells. So they would be IgEs and cell-mediated, and these tend to be more chronic. And then we can have ones that eventually develop into just cell-mediated. And so again, this is in some ways like you're transitioning into a type 4 response, but it was initiated by a type 1 response. So again, because those mast cells, those basophils are recruiting in additional immune cells, if they recruit in T cells, we're just going to start to see more of a type 4 response. So again, so you can kind of think of that. We're transitioning because of the recruitment, because of the inflammation that occurred. So again, with acute responses, where these are just IgE mediated, we can see different effects. So we can see skin effects, things like hives, itching, swelling of the skin area. So again, if that would present clinically where we can visually see that. And again, those mechanisms would be that the allergen's present, there's been exposure to the allergen, the IgG antibodies bound to it, and it's been bound to a mast cell, so the mast cell has degranulated. So we'd have histamine release, cytokine release, and such. We can also have it where we have an oral allergy. So this is where we're going to get itching and swelling in the mouth. So this is kind of, we would see this kind of as a progression. We can also get gastrointestinal effects. So this is where the individual would become nauseous, vomiting, intestinal pain after exposure. This can develop into not anaphylactic quite yet, but we can have issues with breathing. So exposure to the food allergen can lead to wheezing, asthma, and runny nose, rhinitis. This a lot of times is if the food protein is actually aerosolized and they inhale it, this can get into the respiratory tract, and this is where we would develop those symptoms. A more severe one is where we would have anaphylactic, and so again, this is where we get the airwaves, the respiratory tract swelling to the point that we can't move oxygen. We also get drops in blood pressure, which causes the heart not to be able to pump the blood. And so these can actually lead in cardiovascular failure. So again, these are severe allergies. Not that other symptoms aren't of concern and can affect quality of life, but obviously anaphylactics, that can be lethal in exposure. And you hear about that in the news where there was an exposure in a setting where they didn't know what the food was made with or whatnot, and a child usually is exposed to an allergen like peanuts, and that triggers an anaphylactic reaction. And we can also get exercise-induced anaphylactics. And so this, though, is when exercise occurs after eating the triggered food, the individual goes into anaphylactic. So it's partially due to the stress of, so you can kind of think of this as you already have the baseline reaction, and then you exercise, and that induces enough stress to the system, so that then induces anaphylactics. So if the person didn't exercise, they wouldn't have gone into anaphylactic, because they did, and they had been previously exposed to the food. That causes them to go into anaphylactic. So I actually know someone who that happened to. They actually have an avocado allergy, and so they were running the Boston Marathon, and they had decided to use a new training supplement. And so one of the undisclosed allergens on it was avocado oil. That was what natural ingredient. And so around mile 20, they actually went into anaphylactic reaction. So they didn't typically have an anaphylactic reaction to the avocado, but because they were running a marathon, that put enough stress on them that triggered an anaphylactic reaction because of that exposure. Luckily, mile 20 is right near a hospital. So someone found her and they immediately brought her to the hospital, and she's okay, but she definitely a very scary thing. And definitely she's more mindful of not trying out new supplements in training. And she's actually gone on to develop, because she had a prior allergy asthma issues, and she's actually gone on to develop an autoimmune disorder that targets her lungs, and so she's also dealing with that. So she isn't running quite as much, well, nearly a fraction of what she was. So in some cases we can have cell-mediated involvement also, and so in this case, this is where we get atopic dermatitis, where a rash might develop. This is commonly seen in children, and then also we can have this so we can have gastrointestinal effects that are just IgG mediated, but we can also get it where it's cell mediated, and this is going to cause more inflammation. So this is where the symptoms can become more painful. They can lead to late weight loss, and we can also get eosinophil involvement in this. Okay, and then lastly, this is where this is cell mediated, and so this is where we now have activation of T cells, and typically this causes intestinal inflammation. So we can have like IBS type responses when we have exposure to the allergen. So this is seen a lot of times in young children with like cow's milk. So if they have a cow's milk allergy, it becomes progressively worse. And so we would see things like profuse diarrhea, poor growth, loss of weight, and even to the point where we get bloody stools, which means that the lining of the intestine is being affected by that. So again, you should understand the progression and severity and different symptoms that we would see with these allergies. We also want to keep in mind that there are a number of factors, as I mentioned, that put individuals at risk of developing allergies. And so there are environmental factors that put individuals at risk. So we can have these predisposing factors. So if we live in areas with high air pollution, also westernized countries, because of different foods they're eating, there's also, again, this goes into the hygiene hypothesis, where there's been big shifts in our gut microbes. And so individuals in westernized countries, like the US, end up having low gut diversity, low gut microbial diversity. And so there's a lot of microbes that used to be present in prior generations that aren't present now. And so this is where we see like probiotics being marketed with the idea of increasing our gut microbe diversity to provide overall health, but with potential of helping our immune system respond better. So it's not responding to these allergens in such a hypersensitive response. We also tend to have a lower fiber diet. And so that also is thought to be a contributor to the increase in allergies that we're seeing. There are a number of protective factors. So we know that individuals that live in rural areas, in farm environments, they tend to have less allergies. And so again, part of this is the thinking is that they also end up having a more diverse gut microbe. And so by being around other animals, livestock, you're actually being exposed to those microbes, and those actually become part of your microbial diversity. So it's kind of like you're getting farm probiotics constantly. And then we also have a high fiber diet. So making sure you're eating your veggies. Those veggies would also contribute to your gut microbial diversity, because those veggies, regardless of how much you wash them, you should wash them so they're safe, but you don't need to sterilize them. They would actually inoculate you with gut microbes. And so all these protective factors lead to a better barrier integrity, so that the epithelial layer better protects against allergens being able to cross that epithelial layer, and also immune cells being able to cross that. So when we have these factors that are going to increase our risk of allergies, what happens is this epithelial layer gets disrupted. And so in that epithelial layer being disrupted, that's going to allow the allergen to cross in. It's also going to allow for immune cells to cross out into that lumen. This could be the lumen of the gut or in the respiratory tract. And so again, when we have that crossing happening, this allows for those interactions to occur. IgGs get produced, they bind to those mast cells, degranulation activation. Okay, so this phenomenon, when it happens in the gut, is known as leaky gut syndrome. And so there's other factors such as antibiotic exposure can also lead to like leaky gut, but these other predisposing factors also put you at risk. There's a number of genetic factors also. So genetic factors can make it more likely that you're going to have eosinophils and the basophils and mast cells present versus not having them present too. So as I mentioned, there's a number of genetic factors that put you at risk. And so these are some of the different susceptibility genes that have been identified that lead to allergic diseases. And so again, these can have different sites of activity, and you'll see on the right side the different genes, right? So things like that factors, genes that control epithelial barrier integrity, innate response, so how activated the innate system is to pathogens, to allergens, chemokine production, cytokine production, immune tolerance, right? So we only need to make sure that we have the T regulatory cells. And so one of the things that I didn't mention in the previous slide is that when we look at those risk factors, we also see shifts in T regulatory cells. So individuals with allergies and also autoimmunity tend to have lower levels of T regulatory cells. And we also see that in countries where there's less interacting with the environment, less farm activity, less diversity of the microbes, less exposure to benign pathogens. And I think that's kind of a oxymoron, but there's pathogens that don't tend to be harmful, but our immune system can still respond to. So these kind of beneficial microbes, but still we want the immune system to keep them in check. And so when we see a decrease in those, we also see decrease in T regulatory cells. And there's a number of genes that have been looked at that put you at susceptible to having these lower level of T regulatory cells. Also different genes that control cell activation, so T cells, mast cells, and the xenophils, and then additional genes too. Okay, so in this figure, it's showing you how we have an allergen exposure and the difference in the response between exposure through the skin versus an intestinal challenge. So you can see here we have our allergen, which is shown in our little green. And here we have the loss of the epithelial integrity. And so the dendritic cell is able to come through and pull that allergen in. And then it's going to be able to interact with that mast cell and lead to the mast cell degranulation. At the same time, that dendritic cell is going to go back to the draining lymph node where it can interact with the B cell and show that allergen to the B cell. B cell is going to produce IgG and then, again, get the ball rolling with the mast cell becoming activated and degranulating. When we have our challenge occurring in the intestine, again, we're going to still have dendritic cell involvement. Dendritic cell can go back into the draining lymph node to become activated. Because of the difference between the immune cells that are present in the skin versus intestine, we can also have the T cell involvement in the intestine. And so this is where we're seeing when we start to have the symptoms, when we have exposure to the allergen in the intestine, this is going to allow for involvement of cell mediated. And then again, this can where it switches over into a more of a type 4 response where it's cell mediated by itself, because we can get these activation of the T cells and involvement of the T cells. In the intestines, we don't see that classically in the skin, okay? But you can see that we can get mast cell degranulation, mast cell involvement, number of different cytokines that are going to be present also. Okay. So when we're testing for allergies, there's several different ways that we can test. In a physician's office, the classic way, so if you went to an allergist, the classic way is through skin testing or scratch testing. We can also have what's known as patch testing, which is also done on the skin. So there's slight differences in how scratch tests versus patch tests are done, and we'll talk about those. Less commonly, but becoming more common, is where we can do molecular tests, molecular techniques like an ELISA, Western blot, in order to determine the IgG concentrations or what the IgGs are binding to, so just recognition. From serum. We are seeing at-home testing that can be done, looking at IgEs and their presence and what they're recognizing. And so again, we'll talk a little bit about that also. So what we're seeing here is someone's arm that has had a scratch test done on it. So with the scratch test, what happens is a small amount of the allergen is scratched onto, so they put it on the tip of a needle, and the needle is just lightly scratched against the skin. Positive control, histamine, negative control is nothing. And then they put all the allergens onto the needles, and these are all kind of pre-set up and such. So, and then scratched. And then that's allowed to develop for about 30 minutes. And then they come back and they read to look to see whether a hive, a welt has developed. And so you can see for this individual, they have a nice positive control responding to histamine. And then they're also reacting to a number of other allergens and some of the pollens. But then you can see with sheep wool and mold, they're not responding to. So we, again, this is where they would take that information and then come up with either a treatment strategy or stay away from these things as much as possible in that. And so keep in mind what we're looking at here is the mast cells that are located in the skin degranulating, and that degranulation causes that formation of that welt. And so again, what we would classically see as hives. With a patch test, these are more commonly used for chemical allergies. So if you're like allergic to nickel or other chemicals, there are different panels that they can test against. The timing for these are different and they're much more involved. So usually an allergist or physician will first have you do a scratch test because that's a quick, half hour, 45 minutes in the office test. And then they could follow up with patch tests. With the patch test, they apply these patches. So you can see here from one of these FDA approved patch tests. They basically have these little stickers, tapes that have the allergen on it. That's been attached to the individual. Usually this is on the back. So it's, you can cover it up. So not, because these stay on for 48 hours to longer. So patient comes in day 0, they apply the patches stay on for 2 days, patient comes back, the patches are taken off and then evaluated to see whether there are any hives present, similar to what you would see in the scratch test. In some cases, they will have the patient come back in 72 hours, 48 hours to determine whether there's any kind of late response. And it is possible to have late responses 7 to 21 days after the application on these patch tests. So this one is much more involved because, again, patients coming in day 0, they're coming back 2 days later, and then they're potentially coming 2 days after that for an additional reading, and then potentially coming even after that for additional readings. And so again, but the allergens usually tested on patch test are different than the allergens that are tested on a scratch test. Newer technology that's being used is looking at the IgGs that are present. And so Western blots or more traditionally ELISAs can be done, and where the plates are coated with antigen, and then you are putting a small sample of serum onto that so that you can then test to see whether there is a response, if there's any antibodies to that. Okay. Again, these can be done by physicians, so physicians can collect the blood and then they can send them out to different labs. So anything from like Quest Diagnostic to Spectrum Labs. There's a number of other labs, so I'm not trying to preface one as being better than the other ones, in full disclosure. But so they can send them out to the labs and the labs can test them. And the results that you would get back can tell you, it's kind of a yes, no, like, yes, there's antibodies, no, there's not antibodies. And then it will also tell you like how much of that antibody is. You would need to do additional testing to find out the affinity, so how tightly the antibody binds. And so that also, so that has to be kept in mind, because that doesn't, usually in the initial testing that physicians would order, the affinity is not being tested for, and affinity, how strongly the antibody binds, can indicate what the clinical symptoms might be. So one of the reasons why physicians don't always elect to do these is because just because the antibodies are present doesn't mean you're going to have clinical symptoms for it. So sometimes the antibodies, even though they're IgGs or IgEs, they may not present clinical allergy symptoms. And in other cases, some of these panels actually are screening for IgGs. So you have to be careful of which ones you're looking at, because if you're looking at IgEs, then you're looking at type 2 responses, not type 1 responses, which technically aren't in allergies, or a different type of hypersensitivity. So again, I think as more physicians get trained on how to interpret these results, we'll see physicians embracing this. Scratch tests are not delightful, patch tests are not delightful, because you're putting allergens right on the individual skin. But keep in mind that what we were just looking at, that skin is going to be different than what we see with like if it was ingested in intestinal exposure, right? So by doing a skin test, it's a less severe reaction than if we were actually ingesting that allergen. So, but again, at home tests, you would, you purchase this at whatever store you choose to purchase it from. So most of your stores, if you go into, your healthcare aisle, where you would get different medications, they also may have these tests. And so you collect it at home, you put some blood droplets onto a blotting paper and send those in, and then they isolate the antibodies from that, and then you get digital results. Those digital results are meant to be user-friendly. So a lot of times that information that you would get from a physician isn't in there, and those test results, again, it's more like they've determined that this has reached the threshold, and yes, you have enough IgGs to say that you're allergic to it. So they give like a grading of severity, and then they do have platforms where you can interact with a physician to receive guidance on those results. And that piece, I don't know how great those they are, but usually what they're telling you is like, you should avoid these foods because some of the symptoms you might, discomforts you might have might be because you have a sensitivity or an allergy to that food. So there's a number of drugs that can be used to reduce the symptoms of allergic reaction. So the ones that people are probably most familiar with, antihistamine. So this is going to block the histamine activity so that cells that have histamine receptors can't be activated. So things like Claritin, Zyrtec, Allegra, I'm blanking on the name, Benadryl, those can also be used. Leukotriene antagonists are also used. Those aren't as common. Another strategy is using corticosteroids, or also just referred to as steroids. So this is meant to reduce the inflammation. So some of the bystander damage that can be done due to the inflammation of allergic reactions, and also the activation of additional immune cells. So Flonase and Nasacort are corticosteroids. In more severe cases where we might have allergy, asthma, or anaphylactic, this is where epinephrine might be used, or chemicals that are going to block the effect of an epinephrine. So butanol would be one that's used in asthma. And so they do this by binding the G protein coupled receptor, and so that CCAMP can't be produced. And remember, back in the beginning, I was like, oh, don't forget about CCAMP. So CCAMP allows for the degranulation of mast cells, and so things like epinephrine and epinephrine antagonists don't allow for the degranulation of the mast cell because there's not going to be CCAMP present for that cell signaling event. I forgot to mention with antihistamines, antihistamines are blocking the histamine receptors. And remember, I said histamine receptors are found, throughout the body in nervous tissue, both central nervous system and peripheral nervous system. And so with antihistamines, there's concern of the antihistamine passing the blood-brain barrier, and that can have an effect on the central nervous system. So there are first generation antihistamines and second generation antihistamines. So second generation antihistamines would be like Claritin and Zyrtec. Those don't pass the blood-brain barrier as well, so they don't tend to have the central nervous system effects, where your first generation, your Benadryl, those can pass the blood-brain barrier, and that's where you feel the effects of being like really drowsy, because again, it's inhibiting your histamine receptors that are in your central nervous system. Last therapy for treatment is therapeutic anti-IgG antibodies. So antibodies that are going to bind to the IgGs. So these are newer strategies. So these would fall into the biologic category, and are more expensive. So are used in more severe cases and some of the syndromes that can arise from allergic responses. Another strategy besides using drugs is try to desensitize the allergic reaction. So with desensitization strategies, what we're looking at is to give exposure to the allergen in a controlled setting so that we can increase the dose of the allergen, so eventually the individual is desensitized and the immune system doesn't respond to it. It kind of sees it as self, it's always here, why do we respond to it? There's a couple different strategies in order to do that. So we can have where we have injections, so these are referred to as allergy shots. We can also have things that tablets or drops that are put under the tongue, so sublingual application. Sublingual application is now more preferred than allergy shots because, again, entry of allergen is important on what the symptoms are. And so when you do allergy shots, it's more likely to have an anaphylactic episode. So for allergy shots, those are given in a doctor's and a physician's office in case you go anaphylactic. With sublingual, these can actually be done at home because we don't tend to see that. And then we can also have a newer strategy is oral immunotherapy. And so this is where you're fed the allergen. And again, one of the ideas is that we give it increasing concentration. So there've been several studies that have looked at peanut allergies and administering orally peanut allergen and then increasing that over time so that that decreases the severity, at least, of the allergic response. The idea with desensitization is that, we would be retraining the immune cells, especially the dendritic cells, so that they have altered presentation. So instead of presenting to the T cells and saying activate, and then leading to the production of IgGs. So what we're seeing here is dendritic cell is going to present to the T cell. That's going to cause the B cell to switch and cause IgG secretion that can then interact with the mast cell. With desensitization strategies, what happens is the dendritic cell is presenting in a way that says, don't respond. There's a lot of this. There's a reason there's a lot of this, right? So generally the immune system can tell concentration differences. And if there's a lot of something, that kind of sends tolerance, regulation and says, there's a lot of this, I probably shouldn't be responding because this could be myself. And so by giving the allergens that is at a higher concentration than it would normally be found at, this causes the dendritic cell to tell that T cell through signaling events, don't respond to this. So this can cause those T cells that would be able to interact with the B cell to cause it to go isotype switch to IgGs, not be present because those have been deleted, or it can cause it to be suppressed so that it actually becomes a T regulatory cells can act on it so that we don't get the response. So the idea is that you are blocking the interactions that would lead to the production of the IgEs, so those wouldn't be present. And if they're not present, then you can't get mast cell. The mast cells are going to degranulate if you have IgG. So all this is meant to block the production of IgEs. All right, so if you do have any questions, hopefully that gave you a good overview of allergies. Please feel free to email me, ask questions. We'll be going over some of this information in class. So that's also an opportunity to ask questions. But otherwise, thank you very much. And I hope you found it interesting.